Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Nirvi Shah. And let me share some of the achievement of Dr. Nirvi Shah. She has done MBBS, DNB, elective in gynae, onco surgery, fellowship in IVF, consultant at Aviva Fertility Clinic, Khar, West Mumbai. And today she is going to speak one of the very important topic, that is managing patient with poor ovarian reserve, strategies and success rate. To know more about this topic, I would like to invite over to you. The stage is yours. You can proceed from here.
Thank you. Thank you so much. Hi, everybody. So, today I'm going to speak on managing patients with poor ovarian reserve, strategies, and success rates. So, let's first discuss the definitions. So, what is ovarian reserve? It is the quantity and quality of the remaining oocytes present in both the ovaries at a particular age. Ovarian responsiveness is number of oocytes which are retrieved after a ovarian stimulation, whereas ovarian aging is a decline in quantity and quality of the ovarian activity with respect to age. Let's just first go to the basics. Ovarian development. So, basically, in utero, around the fifth week, there are these migratory germ cells around 800 to 1300 which start developing, and in a female fetus, they undergo mitosis. Okay, and a number of germ cells are formed with mitosis to an extent that they are around 5 to 7 million at around the 20th week. Eventually, they undergo regression, and at birth, around 2 million germ cells are there. Eventually, and they undergo prophase of the first meiotic division is the place where they reach. After that, at puberty or at menarche, okay, they get converted into primordial follicles, okay, and there the theca cells as well as granulosa cells are developed, which start secreting FSH and LH. From here onwards, the cycle is a gonadotropin dependent cycle where you see secondary follicles, then there are antral follicles, pre-antral and ovulation, and that's how the cycle goes, the ovulatory cycle. So, like I said, at birth there are around 2 million germ cells, okay, and then it goes on decreasing from menarche. There are around 4 lakh to 5 lakh germ cells, and then eventually it goes on and on decreasing. That is why age is the most important factor with respect to fertility and with respect to oocyte. So, what are the possible causes of decreased ovarian reserve? Of course, one of the causes which we just discussed is advanced reproductive age. Apart from that, there is genetic cause which could be a family history of early menopause, or there can be conditions causing ovarian injury, like people having ovarian cancers, undergoing radiotherapy or chemotherapy. Even endometriosis is associated with a decreased ovarian reserve. Also, there are many lifestyle and environmental factors which have been noted. Then there's autoimmune disorders and genetic abnormalities like FMR1 mutation. So that brings us to the next level. That is the ovarian reserve test. How do we analyze the ovarian reserve? When do we analyze? And with what test do we analyze? So the first and most important, obviously, is biological, which is the age. Then we have certain blood tests, okay, of which AMH is the most important. And there are also the dynamic tests, which are not much of use. They are just in the research areas. Then we have biophysical, which comes under USG, where we check for the antral follicle count, the ovarian volume, and the ovarian blood flow. This is also very important. And then you have histological, which is ovarian biopsy, which is also only in the books, not to be done routinely. Okay. So let's see each one of it individually. Like I said, female age is the most valuable parameter with respect to ovarian reserve, the quality of the oocyte, and the number of the oocytes. Okay, so here if you see the live birth rate per ART cycle with respect to age goes on decreasing. Also, Euploidy, meaning a good embryo, a genetically good embryo with respect to female age goes on decreasing, meaning approximately this is the number of oocytes required to get a good euploid, genetically good embryo. So as the age increases, the chances of a euploid embryo goes on decreasing. So let's go to the basics, the blood test for the ovarian reserve. Okay, so day 3 FSH and E2. So FSH more than 15 and E2 more than 75 are considered to be related with decreased ovarian reserve. However, these are cycle dependent, meaning they are to be done on day 2 or day 3 of a cycle. Also, there is a lot of intercycle variation, and just we cannot rely on one abnormal value of FSH. We need to have association with AMH as well as AFC to conclude that the ovarian reserve is less. Inhibin B also, more importantly, is a better predictor of cancellation of cycles rather than ovarian reserve. Its cutoff is 45 picogram per ml. That's the threshold. This is the most important one. Antral follicle count, usually done between day 2 to day 4 of a cycle, done by transvaginal sonography. 2 to 9 mm of follicles are the cohort which we are looking at. The normal range is between 5 to 15 is considered as a normal ovarian reserve. Also, like otherwise, it's a direct measure of the cohort of the follicles which can respond to a stimulation. So it's a good predictor for the IVF specialist to know the number and to counsel the patient. But obviously, it's a observer dependent thing. And also, there is a problem in case of ovarian mass, like if there's an ovarian cyst or there's endometriosis, then obviously we'll not be able to have a good look at the AFC through the transvaginal sonography. AMH, the anti-Mullerian hormone, it is independent of the HPO endocrine feedback. It correlates with AFC, FSH very well. Okay, it declines earlier than the FSH rise. It has a very high sensitivity and specificity. More importantly, there is minimum variability of AMH from cycle to cycle and on any day of the cycle. So it can be done on any day of the cycle, need not be done on the first 4 days of periods. However, there was a study done in 2022 to just differentiate between AFC and AMH, just compared the two. So obviously there's a faster decline in AMH compared to AFC. Also, they both show a very low proportion of concordance with respect to the Bologna cutoffs. We'll come to that a little later. The reproducibility for AMH seems much better than AFC. The antral follicular count in every cycle is going to vary. Okay. However, AFC is still a better predictor of a POR for the IVF consultant in a way that it helps us to individualize the ovulation stimulation protocol. So, AFC, AMH, and to some extent FSH, these three combined gives us a good review for the ovarian reserve for a particular patient. That's what I just said. The AMH, which is secreted by this preantral, large preantral and antral follicles, whereas the AFC is what we are looking at the cohort in the current cycle, which is around 2 to 10 mm. Okay. And estradiol is obviously secreted by all of them. We have FSH, which is there with the small antral and large antral follicles. So when do we subject the women to ovarian reserve test? So we have the ACOG recommendations, okay, which says that women who are more than 35 years old and who have not conceived after 6 months of planning pregnancy should be screened for ORT. And women, if they are less than 35 years and who have not conceived after planning pregnancy for 1 year, they should be screened for ORT, because all of this helps us to guide them to conceive sooner. So there in 2011, Ferrarati et al. In Eschere consensus came up with a Bologna criteria for poor responders, where they suggested that at least two of the following should be positive to consider them as poor responders. One factor is obviously advanced maternal age, which is more than 40 years, or any risk factors for poor ovarian reserve. The other one was any previous poor ovarian response stimulation, meaning less than 3 oocytes were retrieved with a conventional protocol. The third one is obviously our ovarian reserve biomarkers, which is the AFC less than 5 to 7 or AMH less than 0.5 to 1 nanogram per ml. Also, if none of this is there, any 2 episodes of poor ovarian response after maximum conventional stimulation is also considered as a poor responder as per Bologna. Now, this Bologna criteria was not very ideal because there were a lot of debates around the same. Reason being that the Bologna criteria had a very heterogeneous group with respect to age. Okay, like there may be a good ovarian reserve, but the response was poor, or else when there was a poor ovarian response reserve, but the response was good. Okay, they didn't consider any the age group of 35 to 40. A young woman with a poor response still has a better chance at conceiving a euploid embryo compared to an older woman with a poor ovarian reserve. So, female age and number of oocytes retrieved will actually modulate the chances of pregnancy in current as well as future cycles. So, eventually in 2016, they came up with Posidion, that is patient oriented strategies encompassing the individualized oocyte number. This was a very practical approach which helped the IVF consultants to, individualized and give a tailored ovarian stimulation. So let's briefly go through it. It was divided into 4 groups. Okay. So the group one was age less than 35 with a good ovarian reserve, meaning AFC more than 5 to 7 and AMH more than 1.2. However, however, the response was poor in a previous conventional stimulation cycle, where there were 2 subgroups where less than 4 oocytes are retrieved or 4 to 9 oocytes were retrieved. Group 2 was similar, but the age is more than 35 with a good ovarian reserve. So, technically, older woman with a good ovarian reserve falls in group 2, younger woman with a good ovarian reserve falls in group 1. Then we had group 3, where the age is less than 35, meaning younger woman with a low ovarian reserve, AFC less than 5, AMH less than 1.2. And group 4, where the age is more than 35, meaning an older woman with a poor ovarian response. So here this is a table which is what I just spoke about, that good ovarian reserve and younger woman is group 1. Okay, and group 2 is older woman with a good ovarian reserve. However, they have an unexpected poor response in spite of a good ovarian reserve. Now, what could be the reasons for the unexpected poor response? One of the most important thing is asynchrony, that is follicular asynchronization. Second one could be that there's a gene receptor polymorphism. A lot of research studies have been done on this FSH receptor polymorphisms, of which SER680, SER680 is found to be very commonly associated in older women with poor ovarian response. The third option was that there could be a low dose gonadotropin with respect to high BMI, as in, a very low dose gonadotropin was started. So the recruitment of follicles was eventually less and resulting in less number of oocytes at the end of the cycle. The other thing could be less potent gonadotropin. Nowadays, the recombinant FSH has a greater value over urinary FSH. Now, in poor ovarian reserve, where there's group 3, group 4, we are expecting a poor response because the low ovarian reserve plays a major part, and group 4 is the has a lowest prognosis because it's an old age associated with a lower ovarian reserve. So, in that, the reason is either ovarian aging, which is what I told you. Second thing is any ovarian surgery which have been done in the past for endometriosis, for cancer, for any cyst, complex cyst. And then comes genetic FMR mutation is there, or is any karyotyping. And of course, there is unexplained one also. Okay. So, in this Posidion group 1 and 3, since they are young women, the risk of aneuploidy is obviously less. Whereas Posidion group in 2 and 4, where there are older women, the risk of aneuploidy is more. So, position groups help us to counsel patients with terms to success rate, with terms to aneuploidy, with terms to number of retrievable oocytes, and the number of euploid blastocysts. So, what are the measures of success according to the Posidion concept? The concept of more the oocytes, the better, and one more oocyte matters is particularly valid for poor ovarian response patients. So there are two tools to assess and increase the probability of having at least one euploid blastocyst. One of them is the follicle to oocyte index, very commonly known as FOI, and other one is the ART calculator. We just have a detailed look at each one of them. So FOI is defined as a correlation between the number of follicles before we start stimulation and the number of mature oocytes which we retrieve after stimulation. So if the FOI is less than 50%, like I told you before also, either could be low dose of gonadotropin, or it could be polymorphism of the receptors, or it could be a, not the timing of the trigger is not proper, is also a very very common reason for not getting a good number of oocytes, and it could be genetic. Here we have a ART calculator. So ART calculator basically gives two types of prediction to counsel patients. One is the pre-treatment estimation of the number of oocytes required to form at least one euploid blastocyst, and the other is the actual number of retrieved oocytes, mature oocytes, which are going to give the exact number of blastocysts. So the ART calculator basically depends mainly on age, and the sperm count are the major factors for calculating the success rate. So basically, there was this study in 2022 which just told that how many oocytes should be ideal to get one euploid blastocyst. So in the Posidion groups. So they have seen this number of studies have been done in a meta-analysis, systematic review has been made that around 10 to 15 number of oocytes would be ideal, matured oocytes would be ideal to give a euploid blastocyst. Also, the cumulative live birth rate depends on the Posidion groups. In group 1, 2, and 3, still the live birth rate is better than group 4. Group 4 has the lowest prognosis. So now let's just briefly see what are the best practices for ovarian stimulation in Posidion groups 1 and 2. Okay, so Posidion group 1 and 2 are patients with good ovarian reserve. Okay, group 1 is age less than 35, whereas group 2 is age more than 35. Especially in group 2, where the ovarian reserve is at the lower limit, we should consider adjuvants like androgen in those cases. So in Posidion group 1, okay, we start with the stimulation protocol on day 2, okay, after doing a baseline sonography, and then eventually we increase the FSH dose in terms of 50 to 75. Ideal dose to start with is 150 international units, and recombinant FSH is always better than urinary FSH. Also, we can consider adding RLH in the ratio of 2:1 from first day in women who have had a previous poor ovarian response, or there's a history of follicular stagnation. But in Posidion group 2, where the age is more than 35, we recommend to start a recombinant FSH dose of 300 international units daily. Also, in such patients, to extract maximum from that particular cycle, we do consider dual stim approach. What is dual stim approach? That is that you stimulate in the follicular phase as well as the luteal phase. And luteal phase also, after the ovum pickup is done, we again start with gonadotropins as well as the antagonist cycle or a agonist cycle, and then we give GnRH agonist as the trigger. Whatever oocytes we get, we just freeze the embryos, and then we do a frozen embryo transfer in the subsequent cycle. Now, RLH can be added again here in group 2 also, from day one of the cycle in an agonist as well as an antagonist cycle. So RLH does have a role, especially in group 2. Now, regarding the trigger, we can consider if it's an antagonist regimen, we can give HCG trigger, or a agonist cycle, we give a HCG trigger. In antagonist cycle, we can give a trigger as GnRH agonist also. And then we do elective embryo freezing if the AFC is more than 16 to prevent OHSS. We can consider pre-implantation genetic testing for aneuploidy in group 2 patients around, especially if their age is more than 38, or if there's any previous history of abnormal genetic baby. Also, if everything is ideal, we can consider single embryo blood transfer in the same cycle if the AFC and AMH are a little less and there is no chance of OHSS. Now, in Posidion group 3 and 4, this is a little bit of challenge, especially Posidion group 4 is a challenge. So, these are the groups with low ovarian reserve. So, less than 35 years, we do prefer adjuvant treatment in the form of androgen, growth hormone, CoQ10. Although there are still a lot of randomized control trials going on for them, because the live birth rate there is not significant of difference. However, there is difference in the follicular fluid, there's difference in the number of cycle cancellations are less whenever the adjuvants are added in group 3 and group 4. After the adding of the adjuvants, then we start with the long protocol. In this, patients pre-treatment with E2 or OC pills is beneficiary to get a synchronization of the follicles. 300 international units recombinant FSH is something which we are looking at in group 3 patients since the ovarian reserve is less. We are planning long protocol, so HCG would be the trigger in such patients. If we are doing an antagonist protocol, then we can either give HCG or GnRH agonist. Now, in group 4, obviously we are giving adjuvants in group 4 also, and we have the similar thing, that is using a long protocol, and pre-treatment is a must in group 4. In group 4 we can think a lot about duostim also to maximize. In fact, in group 3 and group 4, in both we can think about duostim to maximize the number of oocytes from the same cycle. If it's a duostim, then we have to give GnRH agonist as the trigger and then eventually freeze the embryos. We can evaluate the FO and ART calculator for oocyte number, as I have explained before. Okay, if there are inadequate number of oocytes to form a blastocyst, then we can consider embryo accumulation or embryo blanking, meaning we can do subsequent cycles, freeze the embryos, and eventually get the total number of embryos, and then we can do the transfer so that we can get a better rate of blastocyst. Or we can eventually, if you're not doing a duo still, we can just start a new protocol, again a long protocol. If there are adequate oocytes, obviously we're going to do the blastocyst transfer. If there is low FOI, then we have to recheck whether the trigger was okay, whether the timing of trigger was okay. We should have considered dual trigger, double trigger, and we should also, reconsider a new protocol with adjuvants and even a duo stim probably. Now let's go to the adjuvants, role of adjuvants in poor ovarian responders. The aim of all of these adjuvants is to increase the quality of eggs. We have a lot of them. We're going to discuss each of them. So let's first go to growth hormone. It increases the sensitivity of ovaries to gonadotropin stimulation. It enhances the follicular development. It increases the oocyte quality by accelerating the cytoplasmic and nuclear maturation. The dose varies from 4 to 8 international units daily, starting from the day of stimulation. However, we still need further research needs to be done. This Cochrane data analysis says that we need more multicentric trials where we come to know about considering the cost of the growth hormone and its safety also. Further research is required before we can completely recommend it. However, it does decrease the need of the gonadotropins. Next is the androgens. The two most important androgens are DHEA and testosterone. So androgen acts at all the level of the follicles, at the primordial level, at primary, preantral, antral, and your preovulatory. What it does is increases granulosa cells, increases IGF-1, it increases the FSHR receptors. So eventually it increases the sensitivity to FSH. So the dosage of gonadotropin required is less. It also helps in increasing the oocyte maturation, helps in ovulation also. So let's see the dose of DHEA is up to 75 mg, when and how long it should be given. So the effect starts after 2 months of taking DHEA. That's why it comes in the pre-treatment part. And it peaks at 4 to 5 months. DHEA supplementation at least for 6 to 8 weeks before IVF is absolutely recommended to see the effects. Testosterone is around 12.5 mg per day, or there's the spray in patch form, there's 1% gel. So it's usually given for 5 to 21 days before starting the stimulation. So 1 month prior to stimulation. Again, here also the Cochrane data says we still, after removing the high risk bias, there was no longer significance of using DHE or testosterone with compared to live birth rate. With compared to live birth rate, it does decrease again the need of gonadotropins. It increases the oocyte quality. It increases the number of oocytes retrieved. But with respect to live birth rate, there was no significance found. Hence, again, further research studies are needed before we completely recommend it. Again, so this was a study in 2015 which also says the same thing, that though it may improve the quality of the oocytes and the retrieval and less gonadotropin is needed. However, regarding the safety and the quality of evidence is moderate, so we need more trials. So now we have aromatase inhibitors. One of the most common one is letrozole. Okay, so it acts at this level from androstenedione to estrone and from testosterone to estradiol. That's the place where it acts. So it increases basically the androgen concentration by inhibiting its conversion to estradiol and estrone. So in a way, it increases again the sensitivity to FSH. So more number of follicles are recruited, less gonadotropin requirement, good oocyte retrieval, and most importantly decreases the rate of cycle cancellation and also reduces the cost burden on the patient by reducing the total gonadotropin dosage. In 2019, the ESHRI guidelines have included in their recommendation that addition of letrozole to gonadotropin in stimulation protocol is probably not recommended for treating POR. It is essential to acknowledge that we need further well randomized trials are required to draw safe conclusions regarding letrozole administration. So, clomiphene citrate is a selective estrogen receptor antagonist, one more of the adjuvant which can be used along with gonadotropins for follicular growth, and hence in this also it is used in COS so that the number of gonadotropin dosage is decreased. In 2019, ESHRI has said that there are no difference between CC alone or CC in combination with gonadotropin or gonadotropin stimulation alone in terms of safety and efficacy. So CC can be given along with gonadotropin, whereas letrozole still needs further studies. Now, role of LH in POR. So, like I told you in those best practice that RLH can be added, especially in group 3 and group 4. So, how does it act? It again increases the androgen concentration. It increases the androstenedione, and even the endometrial LH receptors, they could modulate the embryo endometrium crosstalk and may help in implantation, though further studies are needed. So it is, like I said, it is used in two subgroups. One is women more than 36 years of age, and in group 1 and 3, it can be used where there's a previous history of POR to RFSH monotherapy. In those cases, we can use RLH in the subsequent cycles. So HMG versus RLH in POR. So the studies in 2017 and eventually in 2019, the ESHRI recommendation says that it is still not probably recommended over HMG, doesn't have added benefit with respect to live birth rate. So we still need more trials. Also, our LHS comes at a cost. So we need to consider all of these into factor and need more randomized control trials for the same. So corticosteroids, they are an immune modulator, they alter the NK cell activity and they reduce endometrial inflammation, may be helpful during the peri-implantation period. However, the prognosis is guarded, meaning that there is limited borderline evidence that it may benefit IVF patients. So vasoactive substance like aspirin and arginine, they've said that it increases the ovarian vascularity and improves folliculogenesis, improves response to stimulation. However, the use is still not recommended as per ESHRE because we still need more well-designed studies to prove the same. Now, this CoQ10 also helps in increasing the oocyte quality. So, around 2 months of CoQ10 before starting any IVF treatment would help in increasing the oocyte quality, decreasing the cancellation of cycles, and oocyte retrieval. However, the live birth rates in Indian study, this is Indian study, it did not achieve any statistical significance. Same here also, it did high follicular fluid CoQ10 level is associated with optimal embryo morphokinetic rates, but however, the live birth rate is still not significant. So now let's jump to the newer modalities of increasing the poor ovarian reserve patients. So first one is the in vitro activation of oocytes, more of science fiction, where what they do is that there have been small studies regarding the same, where oophorectomy is done, a cryopreservation is done, then a fragmentation and P13K stimulator treatment for 2 days is done, culture is done, and eventually it is again retransplanted back to the women. If it's a single surgery, then we just remove partial cortex. We do not do the entire oophorectomy, and we do fragmentation and immediate return we do with a transplantation. However, all of this is still needs a little bit of more research and more studies. Same is with the mitochondrial transfer, where they remove the eggs, they remove the mitochondria from the eggs. Okay, identify the first the preantral follicle, remove the mitochondria from the eggs, then put that mitochondria during the ICSI into the mature oocyte. However, this also requires lot of studies. So intraovarian PRP is something which is still performed because it is the minimal invasive procedure, okay, where during a after a ovum pickup, a PRP can be done, okay, to increase the oocyte yield, the fertilization rate. There has been many randomized controlled trials which have been done. Also, they see that they increase the level of AMH, number of oocyte in subsequent cycles after infusing PRP into the ovaries. However, the studies still need to be done on a large basis to come to a statistical significance. So, ovarian stem cell therapy, the first report was done in 1996. After that, in 2018, also they did ovarian rejuvenation following autologous stem cell ovarian transplant on patients with POI, POR, and DOR. However, there are several concerns related to the safety and effectiveness of this stem cell transplant. So, out of all of these four, the ovarian PRP, that is platelet-rich plasma, is the least invasive and routinely started in patients of POR. Social egg freezing race against time. Yeah, so this is one of the thing which is routinely done now for uh, women who are in their early 30s, not yet decided about marriage, or though married but still not decided about planning a baby. So they can do this egg freezing so that we can freeze the quality of the egg when the age is young. So these are the recommendations from ESHRE 2019. So for poor ovarian response patients, the GnRH antagonist cycle or agonist cycle are equally recommended. The gonadotropin dose, like I told you, It's around 150. Those is 150 to 300. In group 1 and 2 Posidion, we use around 150 and then we step up depending on the response. Whereas in 3 and 4, we directly start with 300. Obviously, with respect to BMI, we have to take a look at that also. But doses more than 300 international units are not recommended. They may do more harm. Also, the recombinant FSH is recommended over urinary FSH. Role of RLH is a little unclear, like I told you, that in group 3 and group 4 it can be used, or in previous RFSH monotherapy when there's a poor response we can consider RLH. CC, that is clomiphene citrate with gonadotropin, is equally recommended compared to only gonadotropin. Whereas letrozole still has a long way to go. We need more studies before we recommend it. Modified natural cycle doesn't have any added advantage over our conventional stimulation protocol in a poor ovarian responder. Purifolitropin alpha is a new drug. It is a long half-life FSH which can be given, which is very easy and patient friendly because it's just given on day 2 of the stimulation, and then obviously we do have to add HMG later on, but it is equally recommended. Dual stim approach, like I told you, it is the approach where you do follicular phase stimulation and you also do luteal phase stimulation, and you trigger with GnRH agonist. You maximize the cycle by taking the oocytes from both the phase. Studies have been done where they've seen that the embryos and the oocytes retrieved from the luteal phase are almost comparable with the follicular phase. Now comes the oocyte and embryo banking. They say it is unclear. So it is basically, if you know oocyte and embryo banking, if you're doing single modified natural cycle or natural cycle, and then we are pooling of the embryos, and then eventually we transfer once we get good number of embryos, and then we can get one good blastocyst of that. So this is the recommendations regarding the role of adjuvants. Like I said, growth hormone, DHEA, CoQ10 and testosterone. All these four, though they do not have a significant difference with live birth rate, but they do have a difference with the quality of oocyte. The total dosage of gonadotropin is reduced. The cycle cancellation rate is less. The number of oocytes retrieved are more. So they may be recommended, though we need multiple randomized controlled trials before they are absolutely recommended. So thank you. Hope you just got the gist of managing POR with respect to the Posidion groups.
Thank you so much for it's a very good, wonderful lecture from your end. I hope this will be very much too helpful to all the participants who have joined to better understanding about this knowledge, and I hope that they will implement on their practical knowledge too. I can see that we have received some questions from the participant. If you allow, with all your permission, shall we take these questions?
Sure.
The first question is Dr. Subramaniam is asking from Chennai, and his question is that can IVF be successful with low ovarian reserve? What's your point of view on that?
Yes, IVF can be successful with respect to low ovarian reserve because we need to stratify that patient with respect to Posidion group, give them a realistic approach with the ART calculator and the FOI index, and we can try if and, we can do dual stim or maybe 2 or 3 cycles, stimulation cycles, and get the embryos, and then we can do a transfer. The success rate
Thank
in
you.
Posidion group 3 and 4 is around 20%, whereas the success rate in Posidion group 1 and 2 is around 40 to 45%.
Thank you so much for answering this question. I hope that Dr. Subramaniam has received his answer. Another question is from Dr. Agarwal, and he is asking what is the success rate of diminished ovarian reserve?
Same, whether it's a low ovarian reserve or diminished ovarian reserve. So they fall into category group 3 and group 4 of Posidion. So if the age is less than 35, that is a young responder but poor ovarian response, she has a better chance compared to a group 4, which is a old and a poor ovarian reserve. Like I said, group 4 is a 20% success rate, whereas group 3 has around 30 to 35% success rate.
Thank you so much once again. I hope that Dr. Agarwal has received his answer. We'll be taking one last question from Dr. Shruti, and she's asking like, what can be the risk factors for ovarian reserve? Can you please point some of them?
For ovarian reserve or ovarian stimulation. So
No, she has
basically, the
written
risk
ovarian
factors
reserve.
for
Like, what are the risk factors for ovarian reserve?
ovarian reserve, the risk factors for decreased ovarian reserve. So decreased ovarian reserve, I just said the causes for decreased ovarian reserve. Okay, so it could be one is age, one is the early history of menopause. There can be ovarian insult, like any ovarian injury related to any ovarian cancer, radiation, chemotherapy. All of those are risk factors for ovarian low ovarian reserve. Any history of endometriosis and a surgery done for endometriosis also decreases the ovarian reserve drastically. And then there are genetic reasons and environmental reasons. Genetic reasons like FMR mutation is one of the reasons. Then there are certain genetic polymorphisms, FSH receptor polymorphisms. All of these come into low ovarian reserve.
Thank you so much for answering all the questions and solving the doubts of all the participants. As I can see, there is no more further questions. I hope you have done justice to this topic and people are able to understand so they don't have any doubts. And it was a great to have you, and we would like to see you in future also. As there is no more question, with all your permission, shall we conclude this session for today?
Yes, thank you. Thank you.
And thank you so much. It was really pleasure to have you. We would like to see you in future also with different topic. Till then, take care of yourself. Thank you so much.
Thank you. Thank you.
Welcome.